Welcome to Webisode 12, where we will discuss which is better, methadone or buprenorphine. I'm Eric Morse, an addiction psychiatrist with over 18 years of experience working in opioid treatment programs. Many opioid treatment programs now offer both buprenorphine and methadone as maintenance treatment options, leading us to ponder which medication is best for each patient. Many patients entering opioid treatment programs already know which medications they prefer, based mostly on their own experience and those of acquaintances. While patient preference is an important factor in deciding which opioid agonist to use, specific patient characteristics can lead to providers to favor one medication over the other. Our job as treatment providers is to provide the prospective patient a menu of evidence-based options and to serve as their consultant for the best choice for them. In a 2017 study, Lee et al. Found that naltrexone is as effective as sublingual buprenorphine for preventing relapses and retaining patients in treatment. Naltrexone can be difficult to start in the outpatient setting. Few patients presenting to opioid treatment programs can endure the withdrawal process without relapse, so naltrexone is rarely an appropriate medication to start in the setting. Naltrexone, by the nature of its actions, is more commonly and more easily started at the end of inpatient treatment. Patients who desire this treatment can be referred to such programs. Methadone, as a full opioid agonist, has a heavier opioid effect as the dose increases. Buprenorphine reaches a ceiling on its opioid effect at daily dose around 16 to 24 milligrams per day. For this reason, some patients find that they still have some opioid withdrawal symptoms, even at maximum doses of buprenorphine. These patients may feel better on methadone. Some practitioners feel patients using heroin, which now often contains carfentanil, won't do well on buprenorphine as on methadone. But thus far, there's no evidence to predict who will or won't respond to buprenorphine. Methadone is more dangerous than buprenorphine in patients using sedative medications like benzodiazepines, barbiturates, gabapentin, or alcohol. Those drugs aren't safe even with buprenorphine. The risk is probably less than with methadone. Patients with co-occurring alcohol or sedative use disorders may be at lower risk for overdose with buprenorphine compared to methadone. Methadone has more drug interactions with other medications than buprenorphine, particularly with mental health medications. Methadone can interact with medications prone to causing prolongation of the QT interval. Patients with pre-existing cardiac rhythm problems may be at higher risk with methadone than with buprenorphine, depending on the type of problem. Methadone may still be the best medication for these patients, but extra care and monitoring may be advisable. Patients with respiratory illness with CO2 retention are at higher risk with methadone than buprenorphine, as are patients with untreated sleep apnea. Patients with central sleep apnea may be at risk with both medications, and a careful risk versus benefit analysis with documentation in the chart is advisable if the practitioner decides to proceed with treatment with either of the two agonist medications. Unfortunately, studies have consistently shown worse treatment retention for patients maintained on buprenorphine compared to methadone. Methadone is cheaper than buprenorphine and patients without insurance coverage for treatment may choose methadone over buprenorphine for that reason. We will never have one medication that's appropriate for every patient with opioid use disorder. Thankfully, we now have 3 FDA medications available to choose from. We want patients to remain engaged in treatment, so it's best to check with our patients frequently to assess their response to their medications. We also want to make sure it's easy as possible for patients to switch medications if one isn't working well. If you have further questions, please feel free to contact your state opioid treatment authority. Thanks again for watching, and keep up the good work.